Thank you again, Secretary Carter. It is a really unique privilege to have the opportunity to introduce and to speak with one former and one current cabinet secretaries in a single morning. So I am indeed a lucky one this morning. Now we're going to have the opportunity to hear from our Secretary of Health and Human Services. Alex Azar was sworn in as President Trump's Secretary of Health and Human Services in January of 2018. His current tenure at HHS is his second tour of duty at the department after serving as General Counsel and Deputy Secretary in the 2000s. He has spent his career working in senior healthcare leadership roles in both the public and private sectors. It's a pleasure to introduce you to the 24th Secretary of Health and Human Services, Alex Azar. Thank you.
Thank you. Wow, I feel like I'm walking into the Hall of Mirrors at Versailles or something with that music coming on. Well, thank you. Thank you very much for that introduction, Dr. Meyer. It's always a pleasure to be introduced by a fellow member of the HHS family. Before his time in the private sector, Dr. Meyer was a director at the Agency for Healthcare Research and Quality at HHS, which plays such a key role in supporting the work that many of you here today do, aggregating and analyzing data to improve patient care. I'm glad to be here because the enthusiasm so many of you have for the future of healthcare is infectious. Infectious in the good sense of the word, not the bad sense of the word. Many of you are innovators who are charging toward a new kind of healthcare system. One that delivers value, puts the patient at the center, and provides affordable, quality care for every American. I suspect many of us share the same vision for our healthcare system, and many of you see the same desires from your patients every day. We all want a system that's affordable. No American should be going bankrupt due to the cost of healthcare services. No American should be stuck with a shocking surprise bill when they leave the hospital. We all agree that we need a safety net for our vulnerable citizens, that we need to maintain the promise of Medicare for our seniors, and that we need to do both in a sustainable way. The cost of healthcare services and prescription drugs should be accessible, transparent, and to the extent possible, predictable. We also want a system where the patient is empowered and in control, not left at the mercy of decisions and forces they don't understand. Almost every one of us at some point has felt how disempowered today's system can make patients feel. I'm the Secretary of Health and Human Services, and I have spent more hours than I can count trying to find out how much a service a loved one or I need might cost, what might be the highest quality option, or whether it's even covered by our insurance. Finally, we all want a system that's high quality, a system that makes you feel like a person, like a valued patient, not like a number. Quality care means quality outcomes and care that keeps you healthy rather than only comes in when you are sick. So how do we move to that kind of system? How do we deliver the affordability that patients need, the options and control that they want, and the quality that they deserve? Today, I want to lay out to you several ways that this administration has worked toward these goals, and some sense of where we believe we need to go next. I'll start with affordability, because that's first and foremost in the minds of so many American patients. Half of American families fear that a major medical expense could bankrupt them. The average four-person American household spends a stunning $28,000 per year on health care costs. $28,000 per year for an average family. The lowest price silver plan on the Affordable Care Act market available here in Boston costs $975 a month for a family of four with a $4,000 annual deductible. Even seniors on Medicare face substantial costs, such as those who have hit the catastrophic phase of Medicare Part D, as more than 1 million seniors do each year, facing upwards of $5,000 in out-of-pocket drug costs. Governments at all levels are burdened too. At current trends, the federal government is on track to spend 40% of its budget on health care by 2048, a level that states like Massachusetts have, I'm sorry to say, already reached. These problems demand a comprehensive set of solutions. We need to provide Americans with financial peace of mind. We need to drive down underlying health care costs by harnessing competition and paying for value. And we need to do it in a way that is fiscally sustainable. Take the way we're looking at prescription drugs. This week, in fact yesterday, the comment period closed for our proposal to make Medicare Part D's current system of backdoor rebates replaced with a new system of upfront discounts delivered directly to the pharmacy counter. By requiring these discounts to be passed on to patients, we'll not only provide dramatically lower out-of-pocket costs, especially for seniors with the most expensive drugs, we'll also provide more predictability around seniors' health spending. No longer will seniors picking up their first prescription of the year in January be hit with having to pay based on the full undiscounted list price of a drug. Meanwhile, the President's 2020 budget proposed the first ever out-of-pocket cap for Part D. Now, that kind of peace of mind does come at a budgetary cost. But by improving incentives within the Part D program to harness competition and deliver better value, the budget actually reduces federal spending in Part D at the same time it provides more protection for seniors. This drive toward value is also reflected in a model we put forth earlier this year from the Center for Medicare and Medicaid Innovation, which will allow Part D plans to test approaches to better align incentives to keep drug costs low. It's crucial for these changes in financing to drive more competition and value in the underlying prescription drug markets. Moving from backdoor rebates to upfront discounts, as I just mentioned, will drive even more adoption of low-cost generic options, for instance. Over the last 2 years, under former Commissioner Scott Gottlieb, the Food and Drug Administration approved historic levels of new generic drugs, saving consumers an estimated $26 billion already. The FDA has also launched a biosimilar action plan to support the approval and adoption of these lower-cost options. We plan to encourage new competition in that space through the demonstration that we put forth in Medicare Part B, which would secure a share of discounts given on these expensive drugs to other countries, while also spurring more biosimilar competition. A similar approach applies to our work on the costs of insurance and care. We want to offer affordable, sustainable ways to protect Americans from high health care costs, while also supporting healthy competition and driving toward value in the underlying services. In the individual insurance market in particular, Americans who make too much to receive subsidies are increasingly finding themselves shut out of the market altogether. 1.3 million unsubsidized enrollees left the individual market from 2016 to 2017. In total, the individual market under the Affordable Care Act only covers 3 to 4 million more enrollees than it did before the ACA, but at a cost of more than $50 billion in annual subsidies. That's why this administration has opened up new insurance options, including short-term limited duration insurance plans that are now on the market for up to 50 to 70% less than the ACA plans, and association health plans that have cut costs for some employers in half. We've also proposed to inject more life into the individual market through expanding how employers can use health reimbursement arrangements, with as many as 10 million Americans gaining access to new insurance options under our proposal. But part of the reason for high insurance costs is the high cost of underlying services. Last year, the administration put out a historic report on how federal, state, and local policies may be hindering competition in the supply of healthcare services. Americans need more freedom to seek value from lower-cost providers like nurse practitioners or other health professionals who should be able to practice at the top of their licenses. We also worry that there's too little competition among healthcare facilities, in part hindered by regulations like certificate of need laws. Certain federal policies can be driving consolidation of facilities too. This year, we finally began to tackle the disparity between what hospital-owned and independent physician offices are paid for certain services to move toward what's known as site neutrality. The change we made in 2018 alone will save seniors $150 million in out-of-pocket costs this year, address a significant driver of consolidation, and cut taxpayer spending that was driving no added value. Now contrast these reforms to an alternative approach, the government takeover of our healthcare system that many have proposed under the guise of so-called Medicare for all. It is little surprise that these government takeover proposals have scored as costing $32 trillion or more over the next 10 years. This would require an almost 50% expansion in the size of government, financed by new taxes, and it would push the share of federal spending devoted to healthcare to 58%. Now, that's assuming that the government can, by fiat, impose substantial, indiscriminate payment cuts on all providers, a decision that will mean the end of options, control, and quality for so many Americans. There's a better way, and complementing our work on driving affordability, value, and competition is our promise to deliver Americans the options and control that they want and need. The high cost of American healthcare is one source of stress, but another challenge is that you're almost never even able to find out what that cost is, leaving you as a patient feeling not just confused, but feeling utterly powerless. I don't know how many of you have ever tried to get an honest answer about the cost of a health procedure in advance, but I've tried plenty of times. Once upon a time, I thought it was frustrating enough that, say, the Deputy Secretary of Health and Human Services couldn't find out the cost of stitches for my young son in advance. Well, now I can tell you the answers are just as hard to find, even if you happen to be the Secretary of Health and Human Services. Fundamentally, American patients will never have the options and control they need until they have pricing information regarding their healthcare choices. That's why this administration has already taken historic steps around price transparency, including requiring hospitals to post their price lists in a machine-readable format online for the first time, and proposing to require the disclosure of prescription drugs list prices in television ads. Lack of transparency burdens providers too, making it impossible for them to help patients navigate the system. Physicians end up blindly prescribing expensive medicines without knowing what they'll cost the patient or whether there's a lower cost option. I recently personally spent an entire weekend trying to determine whether a drug prescribed for a relative was even covered by her insurance, or whether her plan just preferred her to use a different drug. And you know what? The insurance plan could not tell us. Such basic information as that. To address this challenge, starting next year, we propose to require that Medicare Part D plans make available a real-time pharmacy benefit tool that's already used in the commercial market, which can provide instant electronic access to the kind of information that patients and physicians find so hard to track down today. Just as patients and providers need real access to pricing information, they need seamless access to information about their health as well. Yet few experiences in American healthcare are as disempowering today as trying to assemble or access your own health records. We've already taken major steps to fix this situation by allowing seniors to give private sector apps access to their Medicare data and proposing new rules around the interoperability of health information that will ensure patients have seamless access to their own data at no cost. These measures will deliver American patients and providers more options and more control over their own care. The alternative path that some suggest, a government takeover of our entire healthcare system, would mean much less control for patients and for providers. Nobody would be able to choose among insurance plans or drug plans that offer different benefits and options. This would move us away from what seniors have increasingly shown that they want within the Medicare program itself, where more and more every year choose from the options offered by Medicare Advantage plans, a consumer-driven ecosystem that would be put to an end by proposals for a single government-run system. We want to preserve options and control for patients, not just because they're good things in their own right, They're also essential parts of delivering the care that Americans want because they help provide signals about what patients value, and they provide incentives for the private sector to deliver better, higher quality care. One place we've already seen this occur is in Medicare Advantage, where this administration has opened up opportunities for plans to offer new supplemental benefits. Plans can now offer not just support for a home health aide to assist a senior with their health needs, but even assistance with meals or modifications to their home to avoid falls. No one's telling these plans exactly what they can offer. They can offer services that they think will lower patient costs, and seniors show what they value most. The simple nature of these added services tells us something important about what quality means to patients. Quality does mean knowing that you can have access to advanced treatments for complex health challenges. But it also means access to care that gives you peace of mind, that improves your quality of life, that treats you like a person, like a valued patient, not like a number. That means care that considers all your needs and tackles your health challenges long before they become a major challenge. Historically, our government payment systems have not reimbursed generously for the kind of care, especially primary care, that can prevent more serious health challenges. We believe it's time for that to change. This year, we will be unveiling new ways for primary care providers to be paid for the value they deliver to our system and to the American patient. Now, contrast this kind of forward-looking approach with the effects of a single government healthcare system. The way the federal government currently pays for procedures rather than outcomes explains a great deal as to why our system doesn't place the right value on care that keeps patients healthy and out of the hospital. Medicare has been moving away from this procedure-oriented paradigm for some time, but we have a very long way to go. The last thing we want to do is impose a rigid government system oriented towards services rather than outcomes on all American patients and providers. A government takeover of healthcare will also mean that all of our seniors are just another number, not protected by a special promise of quality and access through Medicare, but competing for attention with every other American, regardless of their need. More than anything, a one-size-fits-all system will be the end of that vital core of quality care, the doctor-patient relationship. Rather than your doctor being accountable to you, they'll be accountable to a far-off bureaucrat in Washington, me. To deliver American patients the quality they deserve, the options and control they want, and the affordability they need, we need to move to a system where patients and providers can work more closely together to drive value. But to give you a sense of the kind of healthcare system we envision for the future, I want to briefly take you back in time. The sponsor of today's conference, Partners Healthcare, is home to America's third oldest hospital, Mass General, the kind of institution that has made American healthcare the envy of the world. The first Nobel Prize winner affiliated with Mass General, and there have been a few, was a physician named George Minot, who received the prize back in 1934. He was an intern at Mass General before going on to serve as a physician at Boston City Hospital. One of the things that set Minot apart was fastidious attention to the whole patient and his rigorous observation of their health. One area in particular that interested him was their diet. Ask patients how they're eating, he thought, and you might be able to understand a lot about what was driving their health. He noticed a pattern regarding the disease of pernicious anemia, which at the time was a deadly, nearly untreatable condition. He was seeing much less anemia among patients who ate a lot of leafy vegetables and pork. Over the years, he experimented with recommending alterations to their diets, eventually realizing that iron in food was essential to healing pernicious anemia. Liver, in particular, was quite effective. Now, George Minot's prescription for pernicious anemia was 1/2 pound of liver per day. And patients had to put up with this before they knew he had a Nobel Prize level insight. In fairness, raw liver juice was also offered as an option if you care to choose that. Thankfully, within a couple of decades, other geniuses discovered that you could isolate the beneficial effects of all that liver within vitamin B12, and that was the end of the liver prescriptions. Think about what that story says about the kind of successes we can have in healthcare when we put the patient at the center when we listen to them, and when providers have the freedom to think about what drives health rather than how we pay to address sickness. Today, thanks to the kind of technological innovations that many of you have been discussing here at this conference, it wouldn't have required all of that note-taking by George Minot to understand why some of his patients were healthier than others. Today, all of that data could be at our fingertips. That's why I want to leave you today with an optimistic vision and an ambitious one. What we need is a healthcare system that allows the free flow of information, data, and price information that pays providers to discover and implement treatments based on all of that data and keeps the patient at the center of that process. Such a system will finally deliver American patients the affordability they need, the options and control they want, and the quality they deserve. With all of your help, I believe we can build that system much sooner than many expect. Thank you so much for the honor of addressing you all today, and I look forward to sitting with Gregg at our fireside chat now. Thank you.
Great.
Excellent.
Please.
Thank you, Rick.
Secretary Azar, thank you for spending time with us this morning and sharing your vision for the Department of Health and Human Services. One of the things that I think this audience would be interested in hearing about is, given your experiences in both the public sector and the private sector, how do you see your role and the role of your agency and your department in terms of striking the balance between regulatory responsibilities and also to help us spark innovation?
Yep. So, listen, obviously I approach healthcare and government in general as what one would describe as a free market conservative. I believe in the private sector, I believe in competition, and I think that's vital to innovation. That being said, so many of the problems that we have in healthcare today are caused by government, by our own programs. You know, we're operating from a Medicare system that was designed and enshrined in statute in the 1960s, refreshed a bit in the 1980s, and that's, you know, it's no surprise then that so much of our healthcare delivery system that frustrates us is the fact that in many respects we're stuck in those decades. So I think having, what did Colin Powell say, if you break it, you own it. Well, we did our share of breaking. It's our job to help fix it because we are the largest payer in any community, so we can drive that change. So I don't hesitate to use our regulatory power if I think it can bring actual market competition and restore and bring back or restore notions of market force, again, keeping the patient at the center of whatever we do, having them be in as much the driver's seat as they can be.
That's terrific. You talked about some of the most vexing problems that you're trying to tackle, like drug pricing, ensuring that we can provide value-based care. What is the role of data and analytics? What do you see that your department can do to harness the enormous amount of data at its beck to help us tackle those problems specifically?
So I'm a big believer in the role of big data, predictive analytics, AI. One of the things you'll notice across the board that we're trying to do at the department is unleash our data, not just for us, but for you. So we're trying to make that data available. We're trying to make pricing information available. We put out in the health IT regulations that we have at the Office of National Coordinator, as well as CMS, we've said we're looking at whether we should have broader disclosure of even negotiated discounts by providers. That type of information will be a very rich stew for basically those of you who engage in AI work. You know, we do AI right now off of big data, like our Inspector General, for instance. So many of our leads on cases that we go after are based on looking at Medicare claims data and doing statistical modeling, and we've got various algorithms to, I like to say we look for disturbances in the force, where something just is popping out that shouldn't be where it is, and that's how we find so much of the fraud in the system. We want to keep investing in that. I did a lot of that in the private sector, so I've seen the yields. They're tremendous. I mean, look, not the sexiest thing, but we're using AI right now in our procurement processes. And based on that, vendor consolidation and performance, we think we'll be able to save up to $790 million a year from those procurement activities just by using AI.
You know, I think that sometimes we fail to remember that you actually are overseeing an organization that is larger than the economy of all but a handful of countries around the world. What are the other areas? You talked about procurement, but the other areas in terms of just the administration of your enormous department where you're trying to focus AI to help move things forward?
Well, again, on that procurement area is one, the fraud area is another. I'm trying to, I would like to see how we could deliver better services to our Medicare beneficiaries through AI. Imagine a world where you could have, where the programs would actually help steer you to the right prescription drug plan. You know, right now we have great plan finder tool, you type your drugs in, and you get basic information out about your expected expenditures under competing plans and competing pharmacies wherever you live as a senior. But imagine not a more directive, but a more facilitated approach where actually the program coached you and advised you saying, this is the one. Like this would actually, if given your health, can maybe even pull in your medical records to spot
context,
future trend. You know, not just what you're on, but what you may end up getting on, and helps guide you there. I mean, what a different patient experience that would be, and how much money we'd save them and the system.
That's incredibly powerful, and I think there are many people here in the audience who would be very anxious to work on that. One of the other challenges that you have, though, is trying to ensure that you make that rich stew of data available, and that you have interoperability, and at the same time that you ensure privacy. And tell me a little bit about your thoughts about how you're going about that as well.
So obviously the patient privacy element is foundational to everything that we do, and that's why we put out these major rules from the Office of National Coordinator and CMS that are part of the whole interoperability and information blocking initiative that we have. We want to ensure that the patient owns their information, it's personal to them, it's portable with them, and it carries forward. But we have to ensure that they are protected in terms of privacy. So that's a balance. We put these rules out. That's why we put them out for comment, to get feedback from you all and other experts to make sure that we do have appropriate protections. So it's always, the challenge always a balance. If we lock it down so tight, we'll get no use. And then on the other side, you could run risk. Give you an example. We have Blue Button 2.0, which is the initiative that we have at CMS to make Medicare claims data available, and we've now required that be published in open API. We've got over 1,400 private app vendors who are working to develop apps that would sit on top of that as a portal for our seniors to be able to get access to their information.
It's terrific. So, Mr. Secretary, thank you for spending some valuable time with us here today, and most importantly, thank you for your service.
Thank you. Thanks, Greg.
Thank you.
So we have the Dartmouth.